Good evening, all wonderful learners out here. So, are you all ready for today's session? So, this is here Dr. Reena, your mentor, and today we're going to have something different, and we're going to start, something for FMG, like so this session today is basically for the FMG. I'm starting the basics. I'm going to take some MCQs and I'm going to try to cover the relevant theory, and whatever I'm going to be taking will be the high yielding points. मतलब जो मेरे को लगता है कि ये बहुत important है और जो आपको आने चाहिए, right? So if you are connected, just give me a hi so that I can come to know कि yes ma'am, everything is okay, ऑडियो विजुअल का कोई प्रॉब्लम नहीं है, राइट? सो व्हाट आई वांट टू so hello everyone, so just give me a wave if everything is okay. So so what I'll be doing is I'll be taking certain topics which I feel that they are high yielding, and I'm going to try to teach you through MCQ. So I'll be taking one MCQ and then I'm going to cover the relevant theory related to it. So let's get started with the first MCQ. Yes, anybody would say a hi? Yes. Thank you, Krishna, Raj, Krishna Raj, and thank you, Renu. चलो, अब start करते हैं. Okay, now let's read on to the first question. The first question, as you can see, it comes from general physiology, right? Now, this question says that, uh, yes, thank you, Ashwin. Now, there is a patch clamp experiment on a neuron, and the student is able to accurately measure the membrane potential. Okay? At the start of the measurements, the students find that the resting membrane potential is minus 70. The student manipulates the preparation to allow for the membrane potential to stabilize at potassium equilibrium. So by patch clamp technique, you can allow a study of a single channel, right? So in this preparation, the intracellular concentration of potassium was 150 and the extracellular concentration of potassium was 5.5. Assuming the temperature to be 37, what is the equilibrium potential of the neuron in this experiment? Minus 70 millivolts, minus 90 millivolts, plus 70 millivolts, or plus 90 millivolts. So this is the question which is related to one of the very important and high yielding point in general physiology, that is resting membrane potential. Now, before I get on to the answer, whenever we speak of the resting membrane potential, we are going to calculate the RMP of, or the resting membrane potential, by knowing the single potential or the single ion potential. So we will be calculating the single ion potential that is calculated with the help of Nernst potential. So one important MCQ now, that whenever we have to calculate the potential of a single ion, what do we use? We use Nernst potential, because when there are multiple ions, we use different equations, right? That is called as the Goldman-Hodgkin-Katz equation. And when we want to calculate the potential for the single ion, जैसे यहाँ पे we are speaking of the potassium, it is called as the Nernst potential. So here the correct answer is B, that is minus 90 millivolts. So how do you calculate this? So if you look into this formula, it seems to be very complicated. Equilibrium potential is RT divided by Fz. What is this? R is a gas constant, T is absolute temperature, F is the Faraday constant, and Z is the valency. Now, this entire thing, okay, we will what do? We are going to substitute this entire thing with 61.5, and we are going to convert the log the natural base of the log, and we will simply take the concentration of potassium outside divided by the concentration of potassium inside. And by doing this, we get it as minus 90 millivolts, right? Now to make it more easier, whenever you are calculating the Nernst potential, you get confused, concentration of ion inside upon concentration of ion outside. हर समय यही कॉम्प्लिकेशन होती है. रिमेंबर, जब भी आप ये कैलकुलेट कर रहे हो, ऑलवेज टेक द हायर वैल्यू ऑन द न्यूमरेटर. तो यहाँ पर हायर वैल्यू क्या थी? 150, that was of the ECF, that was of the ICF, so we took it above. So always take the higher value on the numerator, the lower value in the denominator, and 61.15 is the constant which you are getting by substituting the R, T and Z, right? As far as the sign is concerned, positive and negative, whenever you are getting the negativity inside, that means when there is loss of the positive ions or there is gain of the negative ions, मतलब या तो positive ions बाहर जा रहे हैं या negative ions अंदर आ रहे हैं. So that negativity में the sign will be minus, and if the positive ions are coming inside, then the sign will be positive. So make it very simple for calculation, that numerator may take a higher value and denominator may take a lesser value, right? Next one. Now, there are students in an introductory laboratory class. Okay, before that, one or two more things I can teach you. So when you teach the resting membrane potential, remember that the resting membrane potential is contributed maximally by the potassium ions. What is the reason? The reason is that this is the ion which is most diffusible at rest. It is the ion that is most diffusible at rest. The reason is that there are different types of channels which are present in the body. There are voltage gated channels, there are ligand gated channels, but there are something which are called as the leaky channels. Okay, leaky channels. These leaky channels are maximally permeable to potassium. So the most diffusible ion at rest is potassium, and therefore the resting membrane potential of an excitable tissue is closest, or we also call that it is nearest to that of potassium. That means it is nearest to that of the equilibrium potential of potassium. So the resting membrane potential is maximally contributed by potassium. It is not by sodium. So don't consider sodium potassium pump. The sodium potassium pump is contributing only minus 4 millivolts to your RMP. But the RMP is maximally contributed by potassium. This is one of the very, very important concept because it is highly diffusible at rest. Now, coming on to the next question. Now, there are students in an introductory laboratory class which are able to isolate the apical and the basolateral membranes from undifferentiated and differentiated gut epithelial cells. Following isolation, the students can categorize the protein, the lipids, and carbohydrates. That means this is the question which is related to your cell membrane. So often, when we consider physiology, we always think that CNS, CVS, RS are more important. But let me tell you, general physiology is a must-known topic. You have to know the general physiology. So the results from these experiments help them to draw certain conclusions. Now, what is the conclusion? The cell membranes contain relatively few protein molecules. The cell membranes contain maximally carbohydrates. The cell membranes are freely permeable to electrolytes, not to proteins. Cell membranes have variable protein and lipid content depending upon their location, or the cell membranes have got a stable composition throughout the life of the cell. So what is the correct answer? Anybody can come up with the answer. Sukhbir, I'll get to you. I'll get back to this question. Okay, that the AV oxygen gradient is low in pregnancy, but it should be high as the oxygen. See, Sukhbir, the BMR depends upon oxygen consumption, beta. It depends upon oxygen consumption, right? That is what is BMR, or your basal metabolic rate, that is depending upon the energy which you are consuming. जो AV gradient होता है ना, that is depending upon what oxygen are we taking from atmosphere and how it is getting transported across the cell membrane, respiratory membrane. So it is not the low oxygen. Remember that it is not the low oxygen that the women is taking in. Yes, the correct answer is D. Right now we'll try to sort out this. So सबसे important होता है कि when we consider our cell membrane, it is made up of 55% of proteins, around 45% of lipids, and you can see that only about 1% of carbohydrates are there. So if you consider the ratio, if somebody asks you the ratio of lipid to protein, it is almost 1:1 because 55 और 45 almost equally है. But अगर आपने weight के हिसाब से बोला तो protein is more. So the amount of proteins are more. Very good. Fun mode. Good. So the amount of proteins are more. Now this has got very important property that the cell membrane is selectively permeable. Right? It is selectively permeable. Second important thing, there is a very proper fluid mosaic model where the fluid is the lipid and the mosaics are formed by the proteins. Okay, the fluid is the lipid and the mosaics are formed by the protein. There is a lateral diffusion of proteins, and these proteins are categorized as of two types. One, the transmembrane proteins, that is the integral proteins that can pass through and through the cell membrane. These integral proteins, for example, your G protein, right? Then all the carriers which we have, the pumps which we have, right? All those which are helping in the transport across the cell membrane, they are integral proteins. And you've got peripheral proteins. Now these peripheral proteins can be either present inside, that is towards the surface of the cytoplasm, or they can be present exteriorly, that means facing towards the ECF. So one confusion is there. हमेशा हमको लगता है कि जो हमारे पेरिफेरल प्रोटीन्स होते हैं वो सिर्फ बाहर की तरफ रहेंगे, मतलब जहां पे ECF है, but it is not like that. They can be present either towards the ECF or they can face towards the cytosol, but they are not passing through and through the cell membrane, right? They are not integral. For example, your cell adhesion molecules, some of the enzyme are present only peripherally, right? So they are not integral proteins. Now this, this is the head and this is the tail. So this is a fluid lipid layer. Okay, yes, fun mode, spectrin, anchorin, dystrophin. Yes, very good. Okay, so the fluid mosaic model mein, this is the bilayer layer, and the alignment is such that this fat loving portions, they are aligned opposite to each other. Okay, the fat loving portion, they are aligned opposite to each other, and this is the water loving or the hydrophilic portion. अब इन दोनों के बीच में जो गैप होता है, there is an intermolecular gap through which the lipid soluble substances can pass through. So the lipid soluble substances can pass through the intermolecular gaps or the gap between these two protein heads, right? And the proteins cannot pass. So the only freely soluble ones becomes your gases. Okay? Your gases, your fat soluble vitamins, your steroids, and therefore we apply steroidal creams because they are penetrating. We apply cream that are having a lipid base and they are able to permeate through the skin. There is a very, very important role of cholesterol. This cholesterol plays a very important role in maintaining the fluidity of the cell membrane, maintaining the transmembrane temperature so that it is not very, very stiff. The phospholipids are not coming very, very stiff or very, very close and tightly packed. Just imagine if you take fridge में you take butter, right? और butter को आपने fridge में रख दिया, and when you put that butter on your garam bread, what will happen? It will melt. So that kind of thing is needed if you want to maintain the fluid. If you don't maintain the fluidity of the membrane, then the lateral diffusion of the proteins is hampered. So therefore, one of the very important function is the maintaining the fluidity that is done by cholesterol. Now, next important thing is, which you should know very, very nicely, is the difference in the ionic concentration. Sorry, the difference in the ionic concentrations of the ECF and the ICF. This is a very, very important question. So you can see that the ECF and this is the ICF, and the predominant cation in the ICF is your potassium, whereas in the ECF it is sodium, right? And also your ECF will have more amount of chloride, it will have bicarbonates, and it will have calcium. Your ICF is rich in potassium, magnesium, and anions, that is proteins and phosphate. This repeatedly comes as an MCQ, so just don't underestimate the simplicity of the general physiology. Next one. Now, there is a 60-year-old man who visits family physician with a history of 3 days of abdominal pain, diarrhea, fever. He is diagnosed with gastrointestinal infection with Campylobacter jejuni. He recovers. Okay, so he is totally recovered. That is a very important history. But uske 3 weeks later, he develops weakness and tingling in the legs. The symptoms progress to paralysis. Okay, the symptoms progress to paralysis. So which of the following is the cause of this paralysis? Yes, definitely there is, it is not multiple sclerosis. It is not multiple sclerosis. Antibodies against oligodendrocytes. The correct answer over here is demyelination of the A beta fibers. So what is this question related to? It is related to your GB syndrome, that is your Guillain-Barré syndrome, which is acute rapidly inflammatory demyelinating neural disease resulting in the paralysis and the sensory disturbances, demyelination of the A beta fibers that are resulting in the block, right? So giving you a history of a GIT infection and then telling you that there is an inflammation of the A beta fibers with a motor paralysis. There is nothing related with multiple sclerosis over here, where the question may be with oligodendrocytes. Also remember, 60-year-old man, 60-year-old man may, there are, I mean, the probability of going towards multiple sclerosis is less, because multiple sclerosis is more common in the middle-aged females. It is more common in the middle-aged females. So consider the other important points which are given to you. Now here one thing which is important, which you should remember, is that always, learn the classification of nerve fibers, right? The classification of the nerve fibers, which I'm going to take a separate lecture over it, because it is a very long thing to be done. And how do you classify them as A, B, and C according to the Erlanger and Gasser's classification, where A is myelinated, B is myelinated, and C is unmyelinated or non-myelinated, and have got the slowest conducting velocity because of the least or the smallest axonal diameter. So this is a pending topic from me, because it is a very long topic. There are 2 to 3 classifications. One is the Erlanger classification, Second is the numerical or the sensory classification of Lloyd and Hunt. And the third is a physio-clinical classification. So that requires another separate topic, which we will take on some other day, right? Next question now. Now, a 62-year-old man is going for surgery. Okay, a 62-year-old man is going for surgery and requires intubation. Right, requires intubation. He is put under a general anesthetic, and prior to intubation, he is given succinyl choline to temporarily paralyze the muscles so that there is an easier insertion of the endotracheal tube. Succinyl choline competes with the natural signals at the NMJ, that is acetylcholine, and causes a persistent depolarization. We know this, the function of the succinyl choline, that prevents the muscles from initiating action potential. Now, the action potential of the unparalyzed skeletal muscle is. So, this is a very typical pattern, where you are being given a clinical question, right? A clinical question, and the last line of this question is a simple physiology, which I am expecting. So, when you consider the action potential of skeletal muscle, what is the correct answer? It has got a prolonged plateau potential. It spreads inwards to all the part of the muscle via the T-tubules. It causes immediate uptake of calcium into the lateral sacs of the sarcoplasmic reticulum, or it is longer than the action potential of the cardiac muscle. So what is the correct answer when you consider or when you start studying the action potential of the skeletal muscles? क्या रहेगा बेटा correct answer? Prolonged plateau potential, longer action potential, spreads via the T-tubules, or immediate uptake of calcium into the lateral sacs. No fun mode. The correct answer is B, beta. The correct answer is B. Right? How B now? Why we did take B? B is the correct answer. See. That is, it spreads inwards to all the parts of the muscle via the T-tubules. Now, when you consider the, the sarcoplasmic reticulum of your skeletal muscle, let me tell you that this question was also recently in your NEET PG as well as in your FMG. This topic, that is excitation, contraction, coupling, and the sarcotubular system, is again a high yielding topic with NMJ and with your skeletal muscles. So this T-tubules in the skeletal muscle, they are long and they are narrow. Definitely this is filled with your ECF. The function of this T-tubule is very specific. The function is spread of depolarization. Spread of depolarization into the interior of the muscle. Whereas the function of this L-tubules is the storage of calcium. Okay, the L-tubules or the longitudinal cisterns, the storage of calcium. These T-tubules have got DHP receptors, dihydropyridine receptors, which are voltage sensors. Okay, they sense the voltage. When the action potential travels, they sense, and they bring about a conformational change, and they open over here the channels which are present here, that is those channels which are the rhinodine channels which are present here. Okay, the rhinodine channels which are present here. So their work is spread the depolarization interiorly, right? And that depolarization will open these channels. Now remember that these channels in the skeletal muscle, they never release calcium, which becomes very, very important MCQ. That In the skeletal muscles, when you consider the source of calcium, it is totally this calcium that is present in the sarcoplasmic reticulum, that is the L tubules or the cisterns. They are not at all depending upon the calcium which is coming from the ECF. और इसी को अगर आप कंपेयर करोगे कार्डियक मसल्स के साथ, so you will see that in the cardiac muscles 1/3 of the calcium is from the ICF, मतलब ये जो स्टोर हाउस है, और 2/3, or you can say this is 2/3 of the calcium, 1/3 of the calcium is coming from the ICF and 2/3 of the calcium is coming from the ECF. मतलब ये जो T tubules हैं आपके cardiac muscles में, they are source of calcium. They will release calcium. वहाँ के DHP receptors will release calcium, which will cause the stored calcium to be released. But skeletal muscles में we don't need that. Okay, हमें उसकी ज़रूरत नहीं है, because पूरा का पूरा calcium यहाँ से आता है from the L tubules. They are only voltage sensors. So dihydropyridine receptors or the DHP receptors. Now, one more thing to be remembered, these ryanodine channels, they can undergo mutation. When they undergo mutation, what the patient develops is called as a malignant hyperthermia. Malignant hyperthermia. This is a susceptibility to a person if he's having a high level of that, if he's having an excitable channelopathy where there is a mutation of the ryanodine receptors and calcium is poured out, resulting in increase in the muscle contraction and increase in the muscle temperature. Right? So sarcoplasmic reticulum, sarcotubular system are again very important high yielding topics from nerve muscle physiology. Next one. Yes, Renu, very good. So I'm very happy with all interactive students. I love the students who interact. I really feel good, अरे वाह बच्चे अगर बोल रहे तो I feel very very good. Now next one. There is a 45-year-old woman who develops severe diarrhea while on vacation. She has following arterial blood values: pH 7.25, bicarbs 24, PCO2 24, bicarbonate 10 with a normal anion gap. What is the correct diagnosis? Metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. What is the correct answer? Monica, very good. So Monica will get a Monica will get a chocolate ice cream. Very good, Monica. Yes. It is metabolic acidosis. Right. Because as soon as you say diarrhea, if it is diarrhea, what is going out? Intestinal contents are going out. Okay. The intestinal contents are going out. And when it is the intestinal contents that are going out, right? When the intestinal contents are going out, what is left is with acids. So it is going to result in acidosis. Okay. Now, whenever you are studying or whenever you are trying to solve the acid base, okay, acid base पर अगर कोई question आता है and you are trying to solve that, what is the thing that you're going to first see? The first thing that we are going to see, that whenever we are learning acid base or whenever we are trying to solve a question on acid base, is always look over to the pH. First point, look over to the pH. So if the pH is more than 7.4, definitely it is alkalosis. Very good, Renu. So Renu को भी motivate करते हैं. क्या देना चाहिए रेनू को? रेनू को cup of tea. It's rainy over here today, so Renu will get a cup of tea. Right? Hi, Rizwan. Hope you are doing well. So if the pH is more than 7.4, alkalosis. If it is less than 7.4, it is acidosis. Once you look at the pH and you look whether it is acidosis or whether it is alkalosis, the second thing which we must look upon is the bicarbonates. Okay? Bicarbonates. Now, if the pH is less, right? If the pH is less and the bicarbonates are also less, that means ये दोनों का जो direction same है, right? ये दोनों का डायरेक्शन सेम है, एरो मार्क दोनों का नीचे है, सो इट इज मेटाबॉलिक acidosis. When it is metabolic, the reason is bicarbonate. When it is respiratory, the reason is your carbon dioxide CO2 level. That means respiratory cause will be there. ठीक है. सो पहले आप देखेंगे पीएच, सेकेंड आप देखेंगे बाइकार्बोनेट्स. सो अब अल्कलोसिस में क्या होगा? pH more than 7.4 and bicarbonates more than will always be more. So दोनों का डायरेक्शन सेम हो गया, it will be metabolic alkalosis. अब कंफ्यूजन कब आती है? You find that there is acidosis. ठीक है, और एसिडोसिस अगर हम बोल रहे हैं तो बाइकार्बोनेट्स तो कम होने चाहिए ना, बट अगर एसिडोसिस है और बाइकार्बोनेट्स बढ़ गए हैं, डायरेक्शन ऑपोजिट हो गया, देन लुक इनटू योर PCO2 लेवल. तब आपको दिखेगा कि PCO2 बढ़ा हुआ है. दैट मीन्स अभी इट इज respiratory acidosis and the body is compensating by increasing bicarbonates, right? So remember that whenever the directions are same, it becomes very easy, but if the directions are opposite, then in that case, okay, in that case it is a compensation that is done by the kidneys, also yes, by the kidneys. Okay. Now chronic acidosis mein, if it is a chronic acidosis, what is important? Remember, for chronic acidosis, okay, if it is a chronic acidosis, the most important buffer is ammonia buffer, right? So whenever there is chronic acidosis, the most important buffer with chronic acidosis, the most important buffer becomes your ammonium buffers. This point is to be kept in mind. Okay. Next. Now, there is a 42-year-old man who develops a gastric carcinoma. Did you eat? What did you eat? कौन सी सब्जी लाए थे नीचे से? ठीक, okay. Now, there is a 42-year-old man developing gastric carcinoma, which is affecting the proximal third of the stomach. He is scheduled for a partial gastrectomy of the affected region. Which of the following process will be affected the most after this surgery? Receptive relaxation, peristalsis, retropulsion, or segmentation? Again, you know, the GIT movements are very important topic. So what will be affected over here? Peristalsis. Ayman is saying peristalsis. Anybody coming up with the next answer? आपको क्लू दिया हुआ है बेटा. What is the clue given? The clue given is proximal stomach. Proximal stomach. No, Minu. Now this is what we need to learn. Before I give you the correct answer, let's look on to the stomach. Now see, when you consider your stomach, this is the proximal part of the stomach and the distal or the caudate part of the stomach, and this is your pylorus, right? The main function of the proximal part of the stomach is storage, or it is a reservoir of food. How does it store the food? As soon as we eat food, what will happen? There will be something which is called as receptive relaxation. Okay? There will be something which is called as receptive relaxation. Receptive relaxation. Right, they're going to be a combination of the food. Yes, fun mode. This is a receptive relaxation. That means it can allow large amount of the food to be accumulated without increasing pressure. This is brought about by nitric oxide, by VIP, and obviously by vagus. And therefore, if you go for a bilateral vagotomy, राइट अगर आपने बायलैटरल वेगोटोमी की तो रिसेप्टिव रिलैक्सेशन विल बी abolished. Receptive relaxation will be abolished. So the proximal part of the stomach, it has to store the food. Now this portion will mix the food with the gastric juices, formation of the chyme, and the food will come here. As the food slowly comes over here, what will happen? This closed pylorus will push the food upwards. This is called as retropulsion. This is what is retropulsion, which is called as a jet-like movement. A jet-like movement. So the food will try to come towards the pylorus. This closed pylorus will push the food upward. So you're coming down and up, down and up. And this actually helps in the proper mixing of the food or the chyme with the gastric juices, right? That is the very, very important function of your pylorus. Peristalsis will begin in the mid of the stomach, but when this pyloric sphincter will relax, okay, when this pyloric sphincter will relax, the food will pass from the stomach into the duodenum. Okay, the food will pass from the stomach into the duodenum. Now, if you consider what are the factors affecting your gastric emptying, this is again a very, very important MCQ, that what are the factors affecting your gastric emptying? So the gastric emptying is hastened or it is increased by mechanical distension. As soon as you eat food, there is increase in the volume of the food, right? There is increase in the volume of the stomach. You increase the food. Second, the type of the food which we take. So the fastest emptying is with liquid. Yes, Monica, very good, beta. That even gastrin increases the gastric motility. Good, Monica. So fastest emptying is with liquid, followed by carbs, followed by proteins, and सबसे लेट emptying होता है फैट का. सपोज आप खुद इमेजिन करो, अगर आपने ब्रेकफास्ट में सिर्फ जूस लिया या ब्रेकफास्ट में सिर्फ एक चपाती ली, और you had eggs and cheese in the breakfast, which will be more fulfilling? Eggs and cheese, which will give you a fulfillment of maybe 2 to 3 hours, maybe 4 hours. You won't feel like eating something because fat take a long time to empty from the stomach, right? Now, hello Ajju, good evening. Now, on the other hand, what are the factors that will decrease the gastric emptying? ठीक है, what are the factors that will decrease the gastric emptying? Gastric emptying कब कम होगी? एक तो हमने type of food देख लिया. जब ये food will go from the stomach to the intestine. Now this intestine will be overloaded, isn't it? There will be increase in the volume. There will be a change in the osmolarity of the duodenum, it will become hyperosmolar, the pH will be acidic initially. तो ये सारी चीजें they bring about initiation of the enterogastric reflex and group of hormones which are called as the enterogastrones. जैसे कि फन मोड ने बोला है, जैसे कि रेनू ने बोला है, वेरी गुड. CCK, cholecystokinin. I'll give you the list of certain hormones. These will be CCK, right? These will be secretin, it will be GIP, it will be peptide YY. They are all labeled as enterogastrones, which are going to inhibit the gastric motility because you want time for the food to come and stay in the duodenum so that it is properly digested and reabsorbed. Yes, fun mode. You know, fun mode, I don't know what is your name, but you are giving so many answers. So, ma'am is giving you a piece of cake and a Maggie for wonderful answers. Somatostatin is also a good answer. Remember, because you've answered somatostatin, somatostatin is one of the most important inhibitory paracrine hormone of the everywhere. It is a most important paracrine inhibitory hormone, right? It is one of the most important paracrine inhibitory hormone. Okay, universal, right? Now, next one is, now, if you look into the, this is regarding the stomach which we saw. But when you consider your small intestine and your large intestine, वहाँ पे you get two different types of movements. What are those movements? One is a mixing movement that will only mix the food, and second is going to be the propulsion movement, that means which is going to move the food forward. These mixing movements are termed differently. In the small intestine, they are called as segmentation, but in the large intestine, they are called as hostrations, the mixing movement. Whereas the propulsive movements in the small intestine are called as peristalsis, and in the large intestine, they are called as the mass movements, right? So this is very important. So this is segmentation. आप क्या करते हो कि, see, this is the orid part and this is the caudid part of your GIT. You divide the entire GIT into small segments, right? You are causing contractions. This was an image based question for FMG. ऐसा image आया था, ऐसा type का image, and you were asked what type of movement is this. So आपने इस पे क्या किया, इंटेस्टाइन को स्मॉल 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 सेगमेंट्स में ब्रेकअप कर दिया. उसका फायदा क्या हुआ, you just allowed the mixing by causing the contractions from either directions without forward movement. So this not only mixes your food but also allows the food to come in contact with this mucosal surface. So the food comes in contact with this mucosal surface and this also facilitates absorption. ठीक है, किसमें मदद करता है वो, absorption में भी मदद करता है. ठीक है. Now, on the contrary, when you see your movement, which is your peristalsis, so peristalsis ka movement is again a very very important movement because peristalsis ke upar you get a lots of MCQ regarding the neurotransmitters in peristalsis. Now, this was your segment. As soon as there is entry of food in the segment, what will happen? Now, this is a food bolus, okay? This is the food bolus. So, it is the food bolus that is initiating peristalsis. The food bolus is going to cause stretch. So, there will be stretching. This stretching will bring about the release of serotonin. Finally, the sensory nerve endings of the enteric gastric or the enteric nervous system. The enteric nervous system is also called as the gut brain. It will bring about the release of acetylcholine and substance P, which will cause the contraction of the segment behind the food. Okay, it will cause the contraction of the segment behind the food and relaxation of the segment ahead. This relaxation will be again caused by VIP, by nitric oxide. So this is going to help the food to move forward. Remember, you have got two types of muscles. One is circular and the other is longitudinal. Both of them will never contract simultaneously. If one is contracting, the other will relax, right? So ये जब फूड के पीछे से हमको कॉन्ट्रैक्शन करना है ना, पीछे वाले एरिया को, मतलब इसका डायमीटर हमको कम करना है. सो यहाँ पर कौन कॉन्ट्रैक्ट करेगा? यहाँ पर कॉन्ट्रैक्ट करेगी आपकी सर्कुलर मसल्स. जैसे फूड वापस आगे चला जाएगा, the circular muscles will relax and the longitudinal muscles will contract. So both of them will never contract simultaneously. Yes, very good, Monica. And fun mode. What is your name, fun mode? Because ऐसे fun mode बोलना बहुत अजीब लग रहा है मेरे को. What is your name? Fun mode. Can you tell me your name? It will be easy for me ना, मुझे अच्छा लगेगा तुम्हें rather than fun mode बोलने से better है मेरे को. I will come to know कि अरे हाँ, this is the name of this बच्चा over here. Yes. Okay. Muntazir. Muntazir. Great. Now let's move on to the next question. Again, one of the very important question, which is from your renal physiology. This question, that is clearance. If you also go through your NEET PG questions, you will find that it has come almost repeatedly. So this is again a very high yielding topic. It is a very high yielding topic. Now, if the clearance of the substance is that is freely filtered is less than inulin, there is a net reabsorption of the substance, net secretion, neither reabsorption nor secretion, substance is bounded to protein or substance is secreted. Very good. Renu and Monica has given up fatafat answers. So Renu and Monica. Very good. Right? Happy. So because it is a rainy season में the best thing is hot Maggie and a hot cup of tea or hot coffee. मतलब my favorites. I don't know about you people. So whenever you are with rainy season, I think hot Maggie and hot coffee go the best combo. So therefore I give only those things which I like. Yes, the correct answer is the net reabsorption of the substance in the tubules. Now, what is the meaning of this question? And this also comes as a calculation based MCQ. Thank you, Renu, for that wonderful heart of yours. Hmm? Now you may be asked to calculate the clearance of a substance X and compare it with the clearance of that of inulin and come to an inference. ऐसा क्वेश्चन भी आता है. अभी देखो. So what is clearance of any substance? It is urinary concentration of a substance divided by plasma concentration of a substance into urine flow rate. Right? So urinary concentration divided by plasma concentration into urine flow rate. Now, it is very important to understand that the units of this urinary and plasma must be same. Now, whenever we have to calculate GFR, we always say that the gold standard is inulin, right? The gold standard is inulin, because inulin is a substance that is only freely filtered. It is a substance that is only freely filtered. It is neither reabsorbed nor it is secreted, right? It is not metabolized. It is not toxic. It is not going to hamper the blood level in any kind. ठीक है? And when we take, but practically what we use is creatinine. Why do we take creatinine? We take creatinine because though the standard is inulin, okay, though the standard is inulin, but we take creatinine because it is an endogenous product of muscle metabolism, and we need not give it to the patient from exteriorly, so the risk is reduced. Now, how much is the clearance of glucose? Let us understand the definition of how much is the clearance of glucose. The clearance is in ml per minute. How much is it? 0, 100, 125 or 70? How much is the clearance? Yes, Monica, correct beta, because it is already present. How much is the clearance of glucose? Normal clearance of glucose? 0, 100, 125 or 70? Very, very common mistake which is done. Very common mistake. The clearance of glucose is 0. Clearance of glucose is 0. Now, ma'am, how it is 0? Because we don't know the definition of clearance. And therefore, we say it 125. What is clearance now? How do you define clearance? So the clearance is defined as the volume of plasma. शॉक हो गया एकदम, रेनू शॉक हो गई। रेनू अभी आप ये देखो। Yes, Ayman, very good. Volume of plasma that is cleared of a particular substance per unit time. Per unit time as it flows through the kidney. It is when we are measuring, clearance, we are not measuring the substance. Actually, we are actually finding out the volume of the plasma that is getting cleared of that substance. ठीक है? So the plasma is never cleared of glucose. Yes, Minu, Monica, अभी तुमको समझ में आया? Monica, Minu, 100% reabsorption of glucose is there. 100% reabsorption. है ना? Glucose never appears in urine unless and until it is diabetic or it is a renal glycosuria or anything which is resulting in an impaired glucose reabsorption. So glucose is 100% reabsorbed and therefore the clearance of glucose is 0. Now, if I give you the same question as a graph. This graph was the NEET PG question last time. Last time मतलब अभी जो हुआ है. Which is showing A, B, C. Which one is showing the clearance graph of glucose? तब क्या बताओगे? Which one is showing the clearance graph of glucose? क्या बोलोगे? A, B or C? Which one is showing the clearance graph of glucose? Right. Now you see B is actually of inulin, which is same as that of GFR because it is neither reabsorbed and it is nor secreted. Now, this is a substance which is initially having zero clearance. But as you increase the plasma concentration of the substance, this starts appearing in urine. That means the clearance of the substance increases. And this is, for example, glucose. Did you get this now? Monica and Ayman, Renu, Pakis, Fun Mode, did you get this? That as you keep on increasing the concentration of a substance which is reabsorbed, for example, glucose, there will be deficiency of the carrier protein. Isn't it? There will be deficiency of the carrier protein. So what will happen? That the carrier protein will become less, the glucose will become more, and 100% reabsorption of glucose will not take place, and therefore its clearance graph will be on the higher side. That means it is appearing in urine. Very good. Yes. Now let's move on to the next question. Again from renal physiology. A 20-year-old woman comes to a clinic for a routine physical checkup that she needs as a part of a summer camp. That means fitness ke liye. The physical examination was within normal limits. Just the urine analysis, it showed traces of protein, a defect in which cell will cause the leakage of the proteins. Mesangial, Bowman's capsule, pericytes, podocytes. Yes. So Monica has come up with the first answer. So Monica, I'm sending you a sapling so that it's a rainy season and you can plant. Each one plant one is a concept. Each one plant one. Right? Yes, the correct answer is podocytes. That means this is a question that is related to the glomerular filtration barrier. Right? So when we consider the glomerular filtration barrier, it is made up of three layers. First is the layer which is made up of the endothelial cells of the glomerular capillaries. Okay, endothelial cells of the glomerular capillaries. Remember that here it is a fenestrated capillary. Fenestrated capillary, that means there are fenestrations, so it can easily allow the substances to pass through it. The second important layer is that of the basement membrane. Right? The second important layer is that of the basement membrane. This basement membrane has got spaces which can allow around particles of 25 nanometers to pass through. But this basement membrane has got something very important, which is negatively charged sialoproteins. And this forms a very, very important barrier. So even if the particle, or like you see albumin, it is very small, it can actually easily pass through the glomerular filtration barrier, but it fails to pass because it is negatively charged and it is repelled by these negative charge ions, so therefore it cannot pass. The third layer is like this: filtration slits, which are formed by podocytes. These podocytes which are coming from the visceral layer of Bowman's membrane. Visceral layer of the Bowman's membrane. Right? So these are the three layers which are protecting the filtration process which are not allowing any substance to easily pass through. Now suppose there are three particles. One is 4 to 6 nanometer cationic, another is 4 to 6 nanometer anionic, and one is 4 to 6 nanometer neutral. Out of this, which substance will have maximum permeability? Which substance will have maximum permeability? A, B, or C? Very good, Monica. Very good. So the best one will be cationic because the membranes are negatively charged and this is positive. So सबसे ज़्यादा it will be attracted. Next one. Yes. Yes, fun mode. Correct. Now, there is a nurse in the pulmonology and clinic administered respiratory test on a subject. After speaking with the subject, he reported to the patient that the FVC is 4 liters. Which statement best describes what the nurse has measured? See, it is a simple physiology just placed in the form of a clinical based question. The amount of air that normally moves in and out of the lung, the amount of air that enters the lung but does not participate in gas exchange, the amount of air expired after maximum expiratory effort, or the largest amount of gas that can be moved in and out of the lungs in 1 minute. So we are speaking of FVC, and what is the correct answer? Yes, very good. Fun mode has given the correct answer. Muntazir, very good. So it is now. We ask the subject to take a deep breath. Okay, we ask the subject to take a deep breath and expire out forcibly. Expire out forcibly. Right? So just expire out. Now this becomes your vital capacity, which is a static lung volume. Okay, this becomes a vital capacity, which is a static lung volume or a static lung volume and capacity. Now look over here. I asked the patient to take in a deep breath. Okay, take in a deep breath and expire out as rapidly, expire out as rapidly, as completely, and as forcibly as possible, as if he's trying to empty his lungs out. So I am getting an extended expiratory limb. I am getting an extended expiratory limb because now I am going to concentrate not only the amount of air. Okay, I am concentrating not only on the volume of air but the speed with which it is given out. So this becomes my forced vital capacity, which is a dynamic lung volume and capacity. So what is a simple what is a simple vital capacity? It is the volume of air that is taken in with a full expiratory effort and given out with an full inspiratory effort. So it is taken in and given out with a full expiratory effort, and the vital capacity is actually giving you an idea of the strength of the respiratory muscles. It is giving you an idea of the strength of the respiratory muscles. But when I speak of the forced vital capacity, which is using adverbs, rapidly, completely, forcibly, I am not only measuring the volume, but I am also looking into the speed. It becomes dynamic. This FVC becomes very, very important. Why it is very important? Because I have to look on whether it is an obstructive airway disease, whether it is a restrictive lung disease, which is given by the ratio of FEV1 to FVC. So we are very much bothered on the first second of expiration. Okay, the first second of expiration, which is called as FEV1, that is forced expiratory volume in 1 second. That means how much volume of air the person expired out in the first second of expiration. Normally, if the person is taking in 100 ml of air, he should be able to expire 70 to 80 ml in the first second. That is the basis of differentiating between obstructive and restrictive lung disease, which we also called as the FEV1 to FVC ratio, or the Tiffin-Hughes index. Okay, the Tiffin-Hughes index. Now, before you look into this, you must know that what is the problem with obstructive lung disease and restrictive lung disease. Obstructive lung disease, like your emphysema, right? The COPD patients, which you classically have, or your bronchitis patient, and restrictive lung disease, like pneumonias, consolidation, parenchymal disorders, fibrosis. So in any condition where the taking in of the air becomes difficult, in obstructive lung diseases, there is a difficulty or there is increase in the resistance to airways more during expiration. Expiration is more difficult, right? Myasthenia. Oh yes, Renu, myasthenia can also be a restrictive kind of a disorder if it is affecting your respiratory muscles. Yes. Now, over a period of time, the person is not able to expire out the complete air. Okay, and the compliance increases because of the increase in the extensibility of the lungs, expansion of the lungs, and the residual volume, the FRC and the TLC, they keep on increasing. But the FEV1 to the FVC ratio is grossly reduced in obstructive airway disease. Remember, FEV1, the numerator, is speaking only about expiration. Okay? It is telling you only about expiration. लेकिन जब आप FVC बोलते हैं, it is including inspiration plus expiration. What is FVC? Volume of air that is taken in and given out. अभी प्रॉब्लम कहाँ पर है? ज्यादा प्रॉब्लम है एक्सपिरेशन में. इसका मतलब ज्यादा प्रॉब्लम है न्यूमरेटर में. इसका मतलब न्यूमरेटर जो डिक्रीज हुआ है वो बहुत ज्यादा डिक्रीज हुआ है एज कंपेयर टू डिनोमिनेटर, and therefore the ratio is grossly reduced, right? Restrictive lung disease में there is a poor compliance. Why there is a poor compliance? Because there is restriction. इसका मतलब there is a difficulty mainly in inspiration. ठीक है? और जितना एयर वो पेशेंट ले रहा है ना, उसके हिसाब से उसका एक्सपिरेशन ऑलमोस्ट ठीक है. There is not much problem with expiration. So this residual volume FRC they will all reduced. लेकिन अगर आप रेशियो देखोगे FeV1 to FVC, this will be normal or increased. Because यहाँ पर the numerator is not decreasing because expiration में कोई भी problem है ही नहीं. There is no problem in expiration. Problem कहाँ पर है? Inspiration. So the ratio will be normal or even increased. Is this very clear to you, this topic? Because this is again very important high yielding topic because respiratory medicine में भी इसका काम आता है ना? So ये हमको समझना बहुत important है. समझ में आया अच्छे से? वेरी गुड मोनिका. मोनिका ने एक सुंदर सा स्टिकर भेजा है एंड आई एम थिंकिंग कि उसको समझ में आ गया. वेरी गुड. एनीबडी एल्स? यस, लेट्स मूव ऑन. नाइट्रिक ऑक्साइड डोनर. रेनू को भी समझ में आ गया. थैंक यू रेनू एंड मोनिका. आई शुड टेल यू दैट आई लव द स्टिकर्स पार्ट ऑफ द लाइफ. इट मेक्स लाइफ मोर ब्यूटिफुल, more exciting. A nitric acid donor which is generating NO, nitric oxide. This is nitric acid. Nitric oxide is infused into the brachial artery of a 22-year-old man. What set of microcirculatory changes are expected? So this question is related to your microcirculation, related somewhere to your capillaries. Yes, Renu, too colorful. Life becomes interesting, exciting, and colorful. And we, by this we can actually make each other happy. We convey emotions more beautifully. We convey colors. We show our interest and love towards people. So I am one of the biggest fan of the stickers. Even in my classes I do the same thing. Even on my WhatsApp I do the same thing. I think spreading happiness is spreading good vibes, and what we need is give unconditional love. The more you give love, the more you get love. And make your smiles contagious, because the smiles are really contagious. If I smile, you'll smile. So make, give contagious things like love and, happiness and positivity. So come back. What will this nitric oxide cause? Increase capillary hydrostatic pressure, increase interstitial hydrostatic pressure, increase lymph flow, increase capillary hydrostatic pressure, increase interstitial hydrostatic pressure, decrease lymph flow. Yes, Joy. It helps in interaction. Very good. Increase capillary hydrostatic pressure, decrease the interstitial, and D. So what is the correct answer? This is basically related to edema type of a question. So I'll be teaching you over here the Starling forces which are important. So correct answer is A. Now, what is nitric oxide? It is a vasodilator. So when you are giving, yes, very good, Renu. It is a vasodilator. That means you are increasing the arteriolar diameter. When you increase the arteriolar diameter, you increase the flow to the capillaries. When you increase the flow to the capillaries, you increase the capillary hydrostatic pressure. That increases the filtration rate, and more tissue will increase the interstitial hydrostatic pressure and the lymph flow. So you are increasing filtration by increasing hydrostatic pressure by increasing the flow by causing vasodilatation. Now, when you speak up of your capillaries, so this is your arterial end of capillary and this is the venular end of the capillary, and there has to be filtration over here and there has to be reabsorption over here, and the 1% that is remaining will be taken care by the lymph. So if there is disturbance anywhere in filtration, in reabsorption or lymph, what will happen? There will be accumulation of the fluid here in the interstitium. This is the interstitium, and what will you get is interstitial fluid accumulation, that is edema. Now, let us make this very, very simple. Remember that these filtration and reabsorption, they are all governed by two important forces, the Starling forces. Okay, the Starling forces. They are by the Starling forces. So you have got two Starling forces, hydrostatic and colloidal, oncotic or osmotic. Right? Hydrostatics are given by P and colloidal, oncotic or osmotics are given by pi. Hydrostatics are pushing forces. Pushing. They will push the fluid out. Right? So, जहाँ पे भी hydrostatic pressure बढ़ेगा, it will push the fluid. Colloidal osmotics are pulling. They will attract the fluid. And we know that the colloidal osmotic pressure is contributed by albumin. So, there will be your capillary hydrostatic pressure. C stands for capillary, and there will be the interstitial fluid hydrostatic pressure. Similarly, there will be colloidal osmotic pressure of the capillaries and colloidal osmotic pressure of the interstitial fluid. Now the answer or the theory understanding becomes very easy. If the hydrostatic pressure is increased, there will be increase in filtration, because the hydrostatic pressure is a pushing force and it will push the fluid out from the capillaries here into the interstitium. From the capillaries here into the interstitium. If you increase the colloidal osmotic pressure, it will pull the fluid into the capillaries. So normally you will see that the pressures are in such a way that there is going to be filtration at the arteriolar end and there is going to be reabsorption at the venular end. Only 1% of the fluid that is not reabsorbed is recirculated by the lymphatics, and therefore if there is a lymphatic obstruction, it results in edema. Got this point? I hope the forces are very easy to you now. Yes? समझा अच्छे से? Now, a newborn with severe diarrhea is found to have inherited defect in a glucose transporter, resulting in the glucose galactose malabsorption, necessitating the glucose and galactose free diet. ओके, फ्री डाइट मतलब उसको डाइट में उसको ग्लूकोज और गैलेक्टोज हमको नहीं देना है. विच ऑफ द फॉलोइंग ट्रांसपोर्ट प्रोटीन इज रिस्पॉन्सिबल फॉर द एंट्री ऑफ ग्लूकोज इनटू द इंटेस्टिनल एंट्रोसाइट? GLUT2, GLUT5 SGLT1, SGLT2, this is a very, very important or a very, very important topic, a very high yielding topic. बहुत ज़्यादा important topic है. NEET PG, FMG, INICT, whatever exam you're going to give. This is very important. मतलब जितना भी मैं important बोलूँ उतना कम है. Just remember जितना मैम exaggerate कर रही है ना उतना ही important है. Yes. Renu, it is SGLT1 beta. 1 is for intestine and 2 is for PCT. GLUT2 is present in the beta cells of pancreas. The GLUT5 is for fructose in the sperm and in the intestine. So this topic becomes very, very important. Now we'll elaborate this topic now. Okay, we'll have an elaboration of this topic because ये topic बहुत important है. Now, glucose reabsorption is active as well as passive. Yes, रेनू. सबसे इम्पोर्टेंट बात जो समझना है वो ये है कि जो ग्लूकोज रीअब्सॉर्प्शन है it is active as well as passive. That means both ways. Through energy, that is SGLT, which is an example of secondary coactive transport mechanism. Secondary coactive transport mechanism. So it is active. Passive with the help of GLUT, which is an example of facilitated diffusion. Example of facilitated diffusion. So glucose is active and passive. Next important is that this SGLT, which is present in the intestine and in the proximal convoluted tubule of kidney, do not need insulin. Do not need insulin. This is very, very important that intestine में ग्लूकोज का कोई भी रोल नहीं है ग्लूकोज रीअब्सॉर्प्शन में. Seems very weird, but it is a fact. ठीक है? And there are glutes. There are about 7 different types of glutes. 1, 2, 3, 4, 5, 6, 7. It is only the GLUT4 which is insulin dependent. It is only the GLUT4 that is insulin dependent. Very good, Monica. This GLUT4 is present in the adipose tissue and in the skeletal muscle. Right? In the, yes, very good, Renu. Good one, beta. Very good. SGLT inhibitor, canagliflozin. Very good. So, adipose tissue and skeletal muscle has got GLUT4. Now, next is that which are the tissues in the body that need insulin for glucose uptake. So, insulin for glucose uptake is needed by 3 tissues: liver, skeletal muscles and adipose tissue. Yes, very good. These two have got the GLUT4, but liver does not have GLUT4. यहाँ पर इंसुलिन increases the phosphorylation of glucose. Okay, insulin increases the phosphorylation of glucose, and this is going to decrease the intracellular glucose level in the hepatocytes. So when the glucose level in the hepatocytes decreases, this itself is going to increase the glucose uptake. Now, how is this glucose reabsorbed? We've seen SGLT and we've seen our, क्या बोला हमने, glutes, तो कैसे reabsorb होता है? So on the basolateral side, you have got the sodium potassium pump, which pumps the sodium outside and takes in the potassium. So this is my basolateral side, and this is my apical or the luminal side. This apical or the luminal side is going to have the SGLT. Okay, the apical or the luminal side is going to have the SGLT. Now what happens that the sodium potassium pump is an example of a primary active transport. It is going to cause a direct breakdown of energy, hydrolysis of ATP, and with the 3:2 coupling ratio, very good Renu, sodium will be pumped out. This is going to decrease the sodium concentration in the ICF. So this creates a gradient for sodium. It creates a gradient for sodium, and the sodium can come inside. As this is a SGLT, sodium glucose co-transporter, and now sodium binds here. But this co-transporter is not going to work unless and until another substance attaches to it. Okay, unless and until another substance attaches to it. यहाँ पर the sodium is going down its concentration gradient because the sodium concentration inside the cell is less. Why less? Because the sodium is pumped out by the sodium potassium pump. So the sodium concentration inside is less. So what will happen now? Glucose will bind here and complete the SGLT. So it is the glucose which is moving against the concentration gradient, and the sodium is moving along the concentration gradient. The use of energy is indirect. Why indirect? Because it did not break ATP. ATP was broken by the sodium potassium pump and a gradient was established. That gradient is utilized by the SGLT, and therefore the use of energy is indirect. Once this glucose comes inside, this will be your glute, which will take the which will take the glucose across the basolateral side. So the functioning of the SGLT is totally dependent on the sodium potassium pump. And if the sodium potassium pump fails, glucose transport will also be abolished. And you had got one MCQ in your FMG, that why ORS may the glucose is added. So in ORS the glucose is added. Not only it is going to enhance the taste, but we know that the glucose reabsorption needs salt. That means when you add glucose, sodium gets reabsorbed. Glucose and sodium together will create an osmotic effect and water will pass them, isn't it? It will pass, I mean, it will flow behind them. So just by adding glucose, you increase the reabsorption of salt and water. So these were the high yielding questions for today. I've tried to cover as much as possible in a period of 1.5 hours. Very soon we will move or meet with our next topic. If you have got any difficulty, please post on over here, right? So that I can come up to your queries. And if you want that I should teach you something, please put in the comment box that ma'am, please take this or so and so session. Your suggestions are always welcomed. So let's make physiology very simple, and let's make our life also very simple by having a great planning, programming, and execution. Be persistent, be optimistic, don't waste your time on unnecessary things, and prioritize. Your priorities at this time are very, very important. So God bless you all. Happy learning and good night.